Hello, everyone. If you can hear me, please raise your hands. Excellent. So today our presentation will be about OCT in glaucoma, in which colors can be deceiving. It's important for day-to-day practice of ophthalmologists because we face that so often. I have no financial interest, and OCT and visual field brands are what we commonly use in clinical practice. So if we look at different reports from glaucoma from different devices, we can see the reports from optic nerve head, from the OptiView or the ganglionic cell layer. We also have the 3D scan from the top cone. We also have a cube scan from the Zeiss or the macular cube from Zeiss. Today we'll focus about single reports. And this is what I usually use. So we have different views in the OCT report. So the question is, after validation, when we see glaucoma reports, where do we look first? You usually have a poll, but we will not use it this time because we lack the time. So do we look, for example, at the disk photo, at the thickness map, probability maps, etc.? So what would be our focus today? Our focus today would be on glaucoma suspects. We're trying to detect early to moderate glaucoma cases. We're trying to learn how to be systematic and do it step by step. We try to look at the structure and detecting artifacts which may lead to false conclusions. So how would we do that? There are few reports in the OCT devices that combine both the ganglionic cell layer and the optic nerve head. We will focus today on what we call the hood report, which combine all of them. So this is the panomap from the Zeiss. This is the hood report from the top cone. And this is the combined optic nerve head, retinal fiber layer, and the ganglionic cell layer from the OptiView. Looking at the reports, where do we look first? First, we will look at this image. This is the B-scan image of the circumpapillary retinal nerve fiber layer, which is this green circle surrounding the optic nerve head. So what do we look here? We should look carefully at this, looking at the nerve fiber layer, looking for two things. First is to looking for any segmentation errors, and second, we look at focal thinning, which is the hallmark for glaucoma cases. You may note that in this plot, the temporal fibers are located in the middle, which is usually we use to conventional report in which the nasal part was at the middle of the report. And most modern OCT devices, you can change that the temporal fibers are located in the middle. It's easier to interpret. So this is what we call instant plot instead of the Tisnet plot. In all the reports, the B-scan image, as you notice in this report, is very small, and it's very difficult to judge for segmentation error or for local narrowing. So try to look at your OCT device if you can find some plot like this, where you can better judge for high resolution image for any segmentation error or focal thinning. So we'll take a quick example about segmentation error. So in this case, you can notice that the retinal fiber layer is well segmented, but there is this area here in which the nerve fiber layer is not well segmented, which led to an artificial narrowing in this area. While in this case, it's a well-segmented nerve fiber layer. We can see there are two focal narrowing at the macular vulnerability zones. We will not cover in this area. So this area is highly suspicious for glaucomatous damage. So the first step is looking at the B-scan image. What's the second step? We should look for both the thickness maps and probability maps for both the retinal fiber layer and the ganglionic cell complex. You can see there are thickness maps like these. The one on your right hand and on your left hand are the thickness map for the nerve fiber layer, while this side is the thickness map for the ganglionic cell layer, while these are the probability maps. The one on your left hand is the circumpapillary nerve fiber layer. This is the probability plot for the retinal nerve fiber layer, and the lower one is for the ganglionic cell layer. So for the thickness maps, red is thick, while blue and green is thin. We should notice that. But for the probability maps, it's quite the opposite, in which the green is thick, while the red is thin. And if you notice at the last plot on the left side, it's the on-fast image of the nerve fiber layer. You can clearly see a triangular focal loss of the retinal nerve fiber layer that I would put this red mark on it. So this is the second step. This is the probability map for the nerve fiber layer, while this is the probability map for the ganglionic cell layer. One thing about Hood report, it presents the probability maps in a flipped image, similar to the visual field. So you can see it's marked. There are dots for the visual fields. The larger dots would be similar to this, compatible with the 24-2 visual field, while the smaller dots, it's related to the 10-2 plots. You can see the smaller ones and the larger ones. In a similar fashion, we have also the probability map for the ganglionic cell layer. It's also mapped as a flipped image, similar to the visual field. You can see the larger dots is related to the 24-2, while the smaller dots is related to the 10-2. One thing you may notice here, for the 24-2, only 4 points covering the macular ganglionic cell layer, which may not be at some time sufficient to detect subtle changes at the loss of the ganglionic cell layers. This is different from the conventional ganglionic cell layer clock hour probability map that we usually see. And also, as you see, the points for the field is not regularly placed. This is related to what we call retinal ganglionic cell layer displacements, because the architecture of the retina is placed so that there is this displacement when we're trying to compare the visual field point to the retinal ganglionic cell layer. So it's quite displaced, not regularly as we usually start to think. What's the step 3? This is a very important step, is to look for topographic agreement between nerve fiber layer and the ganglionic cell layer. So let's take this example. First step is to look at the B-scan image. So what we look for? We're looking for a focal narrowing here. You can see it's narrowed. It's similar to this one there. If we look here, you can see there's a focal narrowing and the thickness map. You can see there is a focal narrowing in the on-fast image. This should be in agreement with the ganglionic cell layer. So we look at the ganglionic cell layer. What we see, you can see there's a probability map that should be like this in the visual field. If we look at the ganglionic cell layer, this superior nerve fiber layer is consistent with this loss of the ganglionic cell layer, which is apparent here in the probability map in the visual field. What we should do next, this is step 4. Step 4 is compare it with the visual field. We try to look what best visual field. Is it 24-2, is 10-2, or is it combined for the cases we have. So the OCT can help us guide what kind of field we will use. Going back to this image, if we overlap, you can see the ganglionic cell layer is very consistent with the nerve fiber layer. And if we look at the field, we look at usually the pattern deviation. You can see the visual field is consistent with the field loss of the OCT. This is what we call topographic agreement that's consistent with the visual field. If we look at the 10 that you can see how much this is similar to this visual field of the same patient. This is another example. So first, we look at the B-scan image. We're looking for segmentation. Segmentation is fine. We're looking for focal narrowing. You can see there are two focal narrowing here. One is this, that is consistent with this one, and one is this, that is consistent with this one. Second, we look at probability maps, thickness map for both nerve fiber layer and the ganglionic cell layer. So you can see in the thickness map and the on-fast image, there are focal narrowing. Can you see it? Third, what we do, we look at, this is the probability maps. You can see the ganglionic cell layer probability map is consistent and in topographic agreement with the nerve fiber layer plot. If we compare to the visual field, we can see there is topographic agreement with the visual field. And this is the 10-2. You can see this one is in topographic agreement with this one. So this highlights the importance of having both the OCT and visual field to confirm the diagnosis. So far, we start with a B-scan image. We check for thickness and probability map for both nerve fiber layer and the ganglionic cell layer. We're trying to look at the structure and the function at the same time and compare it with the visual field. There are new visual fields in the new Humphrey devices, that's the 24-2C, that includes 10 additional central units to the conventional 24-2. It's like a hybrid mode that can be used sometimes instead of asking for two visual fields. This is the 24-2C. So we also try to learn what are the common artifacts that we see. Today we'll cover three the most basic artifacts. First is segmentation error. We had a look at one case of segmentation error. We tried to look at another case. So for this case, if we don't look at the B-scan image, this patient has a good quality OCT with a good signal strength. But there is segmentation error here that is leading to this narrowing here. And if we look at the on-fast image, there is no focal narrowing there. That is consistent with this. And if we look at the ganglionic cell layer, there is no focal loss of the ganglionic cell layer. So there is no topographic agreement, and this is one type of artifacts that we see. Another one that's very important, and we see it quite often, is what we call retinal nerve fiber layer shift. What's retinal fiber layer shift? If we look at the B-scan image, you can see these areas. Do you see the shadows below the retinal fiber layer? These are the shadows of the vessels. And usually, retinal fiber layer are thickest parts at with the vessels because they travel with the vessels. So what's happening here? The peak of the nerve fiber layer is consistent with the vessel that is shifted from the normative value. So you can see here, this is the peak, while the peak of the normative value is a little bit to the left. So what happens? There is an artificial narrowing because of the shift at the location of the red arrow. But if we look at the on-fast image, there is no focal loss of the retinal fiber layer. That is consistent with this in the nerve fiber layer plot. And if we look at the ganglionic cell layer, you don't see any consistent loss of the ganglionic cell layer. If we compare it with the visual field, you can see there is no topographic agreement with the visual field. Let's take another example for the nerve fiber layer shift. These are the sites of the vessels. And if you look at the of the retinal fiber layer plot, there are the red lines. The red lines are the lines for the vessels for the normative values. You can see there is a shift, You can see there is a shift in the location of the bezels. This is the peak for this patient. It's a little bit shifted to the left compared to this. So it leads to focal apparent narrowing. But if you look at the on-face image, there is no focal loss of the nerve fiber layer. That is consistent with this one. And if we look at the ganglionic cell layer, there is no focal loss here. So this is what one type of artifact that's called the retinal fiber layer shift. The last example is what we call the foveal ring. If we look at this OCT report, first we look at the B-scan image. Is there segmentation error? No. Is there any focal loss? No. But if we look at this side, at the probability map for the ganglionic cell layer, there is what we call a foveal ring. Other examples of foveal ring. These are for other two patients. It's similar. It's at the fovea, and it usually happens in both eyes. It's related to the retinal ganglionic cell layer displacement in comparison with the normative value. In the normative value, they have less displaced. In these patients, they have more displacement as if they have an apparent loss at the ganglionic cell layer at the fovea. This is what we call a foveal ring. In summary, we have 4 steps. Look at the B-scan, look at both nerve fiber layer and ganglionic cell layer, look for topographic agreement and compare it with the visual field, and we cover 3 types of common artifacts in the OCT and the glaucoma cases. What are the take-home message? First, look at your OCT device and try to get the full potential of it. Don't rely on the report that you usually recommend, and that's it. Remember that imaging diagnose while metrics summarize. Don't rely on metrics to diagnose. The 4, artifacts, they don't show topographic agreement. Artifacts don't align. Glaucoma damage align. And if you have alignment, we are increasing the diagnostic certainty of our case. Common OCT interpretation error, what are? First is trusting colors. If we only look at colors, it's one of the pitfalls in interpreting OCT. Ignoring the B-scan image, especially with our new devices, we have high resolution images of the B-scan of the OCT. Use it, rely on it. And the 4th one is relying on global averages. Thank you very much.
Thank you so much.